the Diabetes Center, and operates, of course, the USF Health Bird Alzheimer's Institute. And joining us now to explain how USF is working to dramatically increase its research and education programs are Dr. Henry Rodriguez, Medical Director of the Diabetes Center and Professor in the Department of Pediatrics, and Dr. Amanda Smith, Medical Director, Alzheimer's Disease Comprehensive Clinical Center at USF. And I welcome you both. Thanks for being here. Two different diseases. Let's talk about diabetes first. I think it's still a mystery disease. It causes so many complications for people, and we don't fully understand why. But let's start with the fact that there are two types, type 1 and type 2.
Correct.
And in the pediatrics, you're dealing with type 1, juvenile diabetes.
Primarily.
Okay. But how quickly is it diagnosed? Does it happen in the womb? I know it does in some cases. Gestational diabetes can cause the child to have diabetes.
Well, not so much. I mean, actually, in children, when the mother experiences high blood sugars during pregnancy, that child is actually at risk for low blood sugars after they're born, because they've been exposed to such high sugar levels. They have high insulin levels. So when they're born, that's a concern. We see type 1 diabetes really from even the newborn period through adulthood. And it's much more commonly diagnosed in children, and that's why it was historically referred to as juvenile onset diabetes. The major difference between type 1 and type 2 diabetes is for individuals with type 1 diabetes, they don't have the ability to make insulin. And so from the onset, they require insulin injections, multiple daily injections every day just to survive.
And some people wear a pump.
Correct.
That actually, they can measure their blood sugar. And it's periodically also, rather than an injection, they're infused with
Correct.
insulin, right?
So insulin pumps, as they currently exist in the marketplace, don't have the ability to adjust insulin delivery based on a sensor. Some of them can display the results of a continuous glucose monitor. It's not measuring blood sugar, which is critical in making insulin dose adjustments. The technology is advancing rapidly, and we're certainly in the throes of evaluating those therapies as they become available.
You want to do more clinical research into this disease. And so that requires patients, obviously, who are willing to be studied.
Right.
Is it easy to recruit people to do that?
Well, I think, my background, I've been at USF now for 2 years. Previously, I was at Indiana University. And what we have here really is a unique opportunity that we've really building upon the existing diabetes care providers in the Tampa Bay area and enlisting their efforts in not only improving the tools that we have available in the education and clinical care for patients, but also enlisting them in really allowing those patients to have access to the latest therapies in the form of clinical research trials.
And Dr. Smith, that's part of what you do too with Alzheimer's.
Yes.
You're doing research, you do animal research, laboratory research, you're doing human research, you have clinical trials. Talk about the comprehensive approach you're taking at the Bird Institute and in your Alzheimer's unit.
Well, we're really uniquely positioned in the world. We're really the only place where you have all of those things going on in one building. We have the opportunity to take some of the things that the basic scientists upstairs discover in the labs and bring them down to the clinic and test them in patients without ever setting foot outside. So it's really a unique setup that we have. And in addition to all of the research, we also do regular outpatient care. A lot of people are under the misconception that they have to be accepted into our program or something. They can just come. We're a regular doctor's office to take care of memory disorders, and we do a lot of education and outreach in the community as well.
How much better have doctors become at diagnosing Alzheimer's or other dementia?
Well, I think that it's only been in the last 10 to 15 years that people really truly see it as a disease. For the longest time,
it was forgetful.
Right.
Senile.
It was considered a normal consequence of aging. And so people just kind of lived with it. And it's only now that we realize that, it's not normal and there are things that we can do to slow it down or possibly prevent it.
Caregivers often are the ones under the most stress with an Alzheimer's patient. But I want to talk about living with someone with either diabetes or Alzheimer's. Completely different, I understand. But for example, if you live with a type 1 diabetic who's insulin dependent and their sugar goes low, they can seem like they're not necessarily having a seizure, but obviously their speech may become slurred.
Certainly.
They may, the worst case scenario will be a diabetic coma.
Correct.
But you have to know what to do to help them because they don't necessarily realize what's going on.
So when you have a family that's dealing with either chronic condition, education is critical.
Right.
So you really have, in the case of a family member of somebody with type 1 diabetes, they need to recognize the symptoms. They need to be very well aware of how to treat. In the case of somebody who perhaps loses consciousness because of a low blood sugar, there's therapy available. It's called a glucagon emergency kit. They have to learn how to give the injection to revive that individual. So it really is, it affects obviously the entire family.
In some cases, just a glass of orange juice may do the trick if you catch it early enough, right?
Exactly.
Or a candy bar, which sounds like the pure opposite of what you should be doing, but that's what happens with diabetes. When the sugar gets low,
Well, if you have someone that is insulin dependent, type 1 diabetes primarily, they're taking insulin. If they don't eat appropriately, or if their activity increases more than usual and so forth, they're at risk for low blood sugar. So again, they need to have a rapid-acting source of carbohydrate or sugar that's going to raise their blood sugar, because that insulin that they've delivered, that they've administered by injection, will lower their blood sugar.
type 2 can be managed primarily with diet and sometimes medication, correct?
Well, so type 2 diabetes, in contrast to type 1, is a condition where your body's resistant to the insulin. So you need more than normal amounts of insulin. And there are individuals that have risk factors. An example, they're overweight. They can manage by just losing a little bit of weight, eating healthier. If that resistance is beyond their ability to make extra insulin, then they require medications. Many of them are oral medications. And if still they don't have the ability to control their blood sugar, then they require insulin therapy as well.
So they would have to inject.
Correct.
Just like a type 1 would.
Exactly.
Right. In each case, I want to ask you about, ultimately, you would love to find a cure for either one of these diseases.
No doubt.
So what are you doing in that direction?
So we at USF are part of a number of national and international studies that are looking to, as an example, there's a study called Type 1 Diabetes TrialNet that I've been involved with for over 10 years. We're screening family members that may be at risk, so we can look at opportunities to perhaps intervene and prevent the disease. We're looking at the ability to perhaps limit the amount of loss of insulin production in somebody that's recently diagnosed. But you're absolutely right. A cure is the holy grail, and that's what we're ultimately after.
And Amanda, the same with Alzheimer's.
Exactly.
All your research really, you're looking for research that can develop drugs that may help slow down the process.
Right.
We're a long way from having a vaccine, but there strides have been made in that area as well.
Well, we've had some major breakthroughs in the last couple of years. One of them is just in defining what Alzheimer's is. It used to be, if I can use the analogy to cardiovascular disease, waiting to diagnose Alzheimer's until somebody has dementia is kind of like waiting to say someone has cardiovascular disease until they have a massive heart attack. There are biomarkers, there's cholesterol building up in your arteries long before you ever get to that end state. And only in 2011 did the FDA allow us to redefine what Alzheimer's is. The disease state of Alzheimer's is not dementia, but in fact the accumulation of amyloid plaque up in the brain. So now, in addition to that, just this past April, the first amyloid imaging agent was FDA approved, so we can actually see that plaque in the brain in people who don't even have memory problems yet. It used to be you could only see it at autopsy.
Which is a predictor. Right.
Exactly.
That's right. Autopsy, the only way to verify Alzheimer's was autopsy.
And now that's not true. And so with this agent, we can, we're not there yet. We're not, it's not an FDA approved use yet, but we will be able, we hope, to screen people who have plaque in the brain and don't have symptoms, and then give them drugs that maybe have failed in some of these trials because we were giving them to people too late. If we can give them to people earlier in the process, we really may be able to stop them from getting demented.
Well, and in fact, isn't there's at least one drug whose purpose was to remove that amyloid protein, the plaque.
Right, and some of them are removing the protein. The problem is that we're giving it to people when they're already demented, so in a way the damage has been done. so to
So it'd
speak.
be nice to see if you can identify the plaque
Before the neurons have died, exactly.
then go after it.
Exactly.
This may be seen far-reaching, but do you see any relationship between diabetes and perhaps vascular dementia? Because we know that diabetes, one of the consequences, a damaging effect on the vascular system, and which could lead to some problems in the brain.
Well, there are some known correlations between diabetes and both vascular dementia, which is dementia due to strokes, as well as Alzheimer's disease. People with diabetes often have other risk factors for strokes and heart attacks. They often have obesity or high blood pressure or high cholesterol in addition to their diabetes, particularly the type 2 diabetics. So they are at risk for vascular dementia, due to all of these other risk factors as well. But diabetes itself is a risk factor.
When each of you do clinical trials, how do you get the word out to people who might be candidates for such a program?
Well, there are a variety of means. We work through diabetes centers as an example. There's a network both nationally and internationally. We rely on media events such as this to really get the word out. It really is a community-wide effort, and getting folks involved, realizing, any family that's dealing with a family member that has type 1 diabetes, they realize the day-to-day challenges that they face. And making them aware that there's a way for them to participate ultimately in achieving that cure is critical.
As you point out, sometimes it is the hand you're dealt with regard to diabetes.
Right.
But in the case of type 2 in particular, it's something that's entirely preventable, is it not?
Well, from the perspective of having a family history, there's no control over that.
Right.
I think sometimes there's a misconception that someone who has type 2 diabetes, it's obviously their fault. We're finding in or less developed areas of the world where they've had a scarcity of calories, that as they begin to adopt, the Western diet, that they're seeing alarming rates of type 2 diabetes. And so it doesn't take that much. If you've got that genetic risk and you have those risk factors, you don't have to be a glutton, so to speak, to develop type 2 diabetes. And I think that's an important message to get out there.
Amanda, genetic risk, and you know that I have Alzheimer's in my family, so I do think about this.
Right.
How much of a linkage has been established? Do we really know?
Well, there's two different animals, so to speak. There's early onset Alzheimer's disease, which is people that get it in their 40s and early 50s. And in that case, there is a very strong genetic risk. If you are the child of a parent who got it in their 40s, let's say, your risk is very high. It's about 50%. However, in later onset, which accounts for 95% of cases of Alzheimer's disease, people that get it, in their 60s and above, there isn't a specific genetic link. There is a genetic risk factor. There's a particular gene called ApoE, and people who carry a version called ApoE4 have higher rates of Alzheimer's disease and perhaps get it a little bit earlier and may have some different response to medications. But it's not a guarantee that you're going to get it. People walk around with ApoE4 and don't get Alzheimer's, so we don't routinely test for that because it just makes people worry. And it doesn't really, give us any information about whether they're really going to get it.
Well, what you told us earlier about identifying the plaque before dementia sets in sounds very, very promising.
It's exciting.
And if you can treat beforehand and be proactive, it sounds like that would be the very best outcome. Dr. Rodriguez and Dr. Smith, I thank you both for joining us here, and thank you for your great work at USF. We appreciate it.
Thank you.
All right, let's go to Kathy.